Okay, let's talk about the sleep-wake disorders. Sleeping is intimately related to mental health. Not only can psychiatric illnesses such as depression and schizophrenia disturb the quantity and quality of sleep, but certain psychiatric drugs can also have the same effect. Furthermore, persistent primary sleep disturbances, which are common, can result in significant psychological consequences. Okay, even in an otherwise mentally health individual. Definitions and classification. Sleep is divided into five distinct stages, as measured by polysomnography. Four stages of rapid eye movement, non-REM, has stage 1, 2, 3, and 4, and we have a rapid eye movement stage, REM stage. Here we have a figure that summarizes the key characteristics of the stages of sleep. Stage 1 represent 5% of the duration of sleep that's been spent in this phase during night. 5%, okay. The characteristic and the EEG findings will be transition from wakefulness to sleep. It has theta waves in EEG. Theta waves are low amplitude spike-like waves from 4 to 7 Hz. Stage 2 represent 45% of the duration spent in this phase during night, of the sleep during night. EEG would represent sleep spindles and K complexes. Sleep spindles, short rhythmic wave forms, clusters of waveform of 12 to 14 Hz. K complex, sharp negative wave followed by slower positive component. Stage 3 and 4, these are slow wave sleep or deep sleep, represent 25% of sleep. Deep sleep, unusual arousal characteristics like disorientation, sleep terrors, and sleepwalking occur in first third of to half of night. EEG has delta waves. Stage 3 delta waves represent less than 50% of the sleep. In stage 4 it has 50%. Delta waves has high amplitude with low frequency, less than 4 Hz. So delta waves less than 4 Hz, 4 to 7, this is theta. Okay. And after that we have alpha, then beta. Okay. REM sleep represent also 1/4 of sleep, occurs cyclically through the night, every 90 minutes alternating with non-REM sleep. Each episode increases in duration. Most episodes occur in the last third of night. Features penile erection, skeletal muscle paralysis, and serial dreaming, including nightmares. The EEG has low amplitude, high frequency with sawtooth waves, like this, sawtooth pattern. So that's it. Okay, sleep can be disturbed or disrupted due to primary sleep disorders, sleep disorder secondary to another mental illness, or sleep disorders secondary to another medical condition, or sleep disorders secondary to the use of a substance. This chapter will focus principally on primary sleep disorders, which are not caused by another medical condition like arthritis or mental illness like depression, and do not occur secondary to the use of substance like alcohol. These disorders are presumed to arise from some defect of an individual's endogenous sleeping mechanism, the reticular activating system, coupled with unhelpful learned behavior like worrying about not sleeping. The primary sleep disorders, in turn, are divided into the dysomnias and the parasomnias. The dysomnias are characterized by abnormalities in the amount, quality, or timing of sleep. They include primary insomnia, primary hypersomnia, narcolepsy, circadian rhythm sleep disorders, sleep-related breathing disorders, sleep-related movement disorders like restless leg syndrome. The parasomnias are characterized by abnormal episodes that occur during sleep or sleep-wake transitions. They include non-REM sleep arousal disorders like night terrors and sleepwalking, nightmares, and REM sleep behavior disorder. Okay. Let's start with insomnia. Insomnia describes sleep of insufficient quantity or poor quality due to difficulty falling asleep, frequent awakening during the course of sleep, early morning awakening with subsequent difficulty getting back to sleep. Sleep that is not refreshing despite being adequate in length. In addition to a daytime tiredness, persistent insomnia can have significant effects on mood, behavior, and performance. It has been shown that insomnia can also lead to an impairment of health-related quality of life, similar to heart failure or depression. Hints and tips. When considering sleep disturbance in mental illnesses, you may find it useful to think in terms of altered sleep patterns rather than of insomnia. While common in depression, it is only early morning awakening that is part of the somatic syndrome. And 20% of people with depression will have atypical symptoms like weight gain, increased appetite, and hypersomnia. Primary insomnia is diagnosed when present for at least 3 months and not attributable to medical or psychiatric illness, substance misuse, or other dysomnia or parasomnia. The numerous causes of insomnia, as summarized in the books, include primary sleep disorders, medical and psychiatric illness, and substance use. However, the books for common causes of insomnia, we have primary sleep disorders like dysomnias, like primary insomnia, circadian rhythm sleep disorder like jet lag and shift work, sleep-related breathing disorders like sleep apnea syndromes, sleep-related movement disorders like restless leg syndrome or parasomnias. Psychiatric disorders are also a common cause for insomnia like anxiety, depression, mania, or schizophrenia. Physical disorders like painful conditions, either the cause is malignancies, arthritis, reflux disease, and so on. Cardiorespiratory discomfort because of dyspnea, coughing, or palpitations. Nocturia because of prostatic hypertrophy or urinary tract infections. Metabolic or endocrine conditions like thyroid disease, renal or liver failure. Central nervous system lesions, especially brainstem and hypothalamus. Substances like caffeine and other stimulants, alcohol, prescribed drugs like selective serotonin reuptake inhibitors, and some antipsychotics. Substance withdrawal syndrome also. Okay, here we have some causes. Let's get back to the text. Let's talk about assessment of insomnia. Assessment involves excluding a medical, psychiatric, or substance-related cause of insomnia. Many cases of primary insomnia are related to poor sleep hygiene. Therefore, it is essential to inquire about sleeping times and patterns and caffeine consumption. It is also useful to obtain collateral information from the patient's sleeping partner regarding sleeping patterns, snoring, and movements during the night. The following questions might be helpful in eliciting the key symptoms of insomnia. Do you fall asleep quickly, or do you find yourself tossing and turning for some time before dropping off? Do you wake up repeatedly in the night, or can you sleep through once you have managed to get sleep? Do you sometimes awaken too early in the morning and then find that you are unable to get back to sleep? Is your sleep refreshing, or do you still feel tired in the morning? If after a full history the cause of insomnia remains unclear, the National Institute of Health and Care Excellence 2015 recommends a sleep diary. Okay. Refer the patient to a sleep specialist for further investigation if there is diagnostic uncertainty or a suspicion of sleep apnea, circadian rhythm disorders, parasomnia, or narcolepsy. Further investigation is likely to include polysomnography. The simultaneous process of monitoring various physical parameters during sleep, including electroencephalogram, electrocardiogram, electromyogram, electrooculogram, blood oxygen saturation, chest and abdominal excursion, mouth and nose air entry rates, and the loudness of snoring. Communication tip. When considering insomnia, ask what is the normal amount of sleep is for the patient in order for them to feel refreshed in the morning, and what time they normally wake up. There is significant individual variation. Here we have some good sleep hygiene tips. Avoid sleeping during the day, exercise during the day but not within 4 hours of bedtime, and maintain a healthy diet. Eliminate the use of stimulants like caffeine, nicotine, alcohol within 6 hours of bedtime. Condition the brain by only using the bed for sleeping and sex, not for reading, watching TV, etc. Go to bed and awaken at the same time each day. Avoid stimulating activities before bedtime like television, games. Instead, engage in relaxation techniques or reading. Try having a hot bath or drinking a cup of warm milk near bedtime. Avoid large meals near bedtime. Ensure that the bed is comfortable and that the bedroom is quiet. Do not lie in bed awake for longer than 15 minutes, but do not watch the clock. Get up and do another relaxing activities and try sleeping later. Okay. How we manage primary insomnia. The most important aspect of management is providing education about correct sleep hygiene. We've talked about that in previously. There is a limited role for medication in the treatment of primary insomnia. Hypnotics may help in the short term, but the development of tolerance to their effect, usually within 2 weeks, possible dependence, and their personal propensity to cause rebound insomnia limit their use. Therefore, they should only be prescribed for a time-limited basis, ideally for use on alternate or occasional nights rather than every night. Again, time-limited basis, ideally for use on alternate or occasional nights rather than every night. Drugs with a long half-life should be avoided to prevent leaving patients feeling drowsy the next day, the chemical hangover, and to avoid accumulation with repeated doses. Commonly used agents include the Z drugs like zopiclone, zolpidem, and zaleplone, and benzodiazepines with a short half-life such as temazepam. NICE 2015 advises that if there is no response to one hypnotic, an alternative should not be prescribed. Okay. Primary hypersomnolence. Hypersomnia describes excessive sleepiness that manifests as either a prolonged period of sleep or sleep episodes that occur during normal wakening hours. Primary hypersomnolence is diagnosed when patients present with hypersomnia for at least a month, not attributable to a medical or psychiatric condition, substance use, or other dysomnia, especially narcolepsy and sleep apnea, or parasomnia. The numerous causes of hypersomnia, as summarized in the books, include primary sleep disorders, medical and psychiatric illness, substance use, and sleep deprivation. The treatment of primary hypersomnia is usually with stimulants such as dexamphetamine, methylphenidate, and modafinil. Here we have the common causes of hypersomnolence. We have primary sleep disorders like primary hypersomnolence, narcolepsy, sleep-related breathing disorders like sleep-related movement disorders, circadian rhythm sleeping disorders, and parasomnias. psychiatric disorders like depression with atypical features, physical disorders like encephalitis and meningitis, stroke, head injury and brain tumor, degenerative neurological conditions, toxic metabolic and endocrine abnormalities, clean-living syndrome, and substances like alcohol, antipsychotics, benzodiazepine, tricyclics, and substances and some withdrawal syndrome of some substances, or secondary to insomnia or sleep deprivation. What about narcolepsy? Narcolepsy typically presents in young people aged 10 to 20 who report an abrupt onset of pervasive daytime sleepiness. It affects around 1 in 2,000 people. Symptoms of narcolepsy are tetrad of irresistible attack of refreshing sleep that may occur at inappropriate times, even in driving. Cataplexy, which is sudden bilateral loss of muscle tone, usually precipitated by intense emotion leading to collapse and lasting for seconds or minutes. 3. Hypnagogic or hypnopompic hallucinations. 4. Sleep paralysis at the beginning or end of sleep episodes. The symptoms arise from elements of REM sleep intruding into wakefulness. Diagnosis is confirmed by observing rapid onset of REM on polysomnography during sleep latency studies. In type 1 narcolepsy, cataplexy always occurs. It is due to a deficiency of hypocretin, or this is orexin, a neuropeptide that regulates the initiation of REM sleep. Levels are low in cerebrospinal fluid obtained via lumbar puncture. It is thought to arise following autoimmune-mediated damage to hypocretin-producing cells in the hypothalamus, triggered following an infection. Over 98% of people with type 1 narcolepsy have a particular human leukocyte antigen haplotype. In type 2 narcolepsy, which is even rarer, cataplexy either does not occur or is atypical. Its etiology overlaps with type 1 narcolepsy, but in general is less well understood. The treatment of narcolepsy includes taking naps at regular times and ensuring sufficient duration of nighttime sleep. Typically, stimulants are needed to reduce daytime sleepiness. Modafinil is first line. Cataplexy, sleep paralysis, and hallucinations at the sleep-wake boundary can be improved by low-dose antidepressants, usually venlafaxine or clomipramine. Noradrenaline and serotonin suppress REM sleep, and so do antidepressants. Circadian rhythm sleep disorders. Circadian rhythm sleep disorder, sleep-wake schedule disorder, is characterized by a lack of synchrony between an individual's endogenous circadian rhythm for sleep and that demanded by their environment, resulting in the individual being tired when they should be awake, hypersomnia, and being awake when they should be sleeping, insomnia. This disorder results from either a malfunction of the internal biological clock that regulates sleep or from an unnatural environmental change, jet lag, night shift work, and so on. Treatment comprises sleep hygiene, enhancing environmental cues regarding time of day, having a dark bedroom, and bright light therapy, and so on. Sleep-related breathing disorders. Abnormalities of ventilation during sleep can cause repeated disruptions of sleep. This results in unrefreshing sleep and excessive sleepiness during the day. Obstructive sleep apnea, sleep apnea syndrome, the most common breathing-related sleep disorder, is characterized by obstruction of the upper airways during sleep, despite an adequate respiratory effort. Typically, an individual will have noisy breathing during sleep with loud snoring, interspread with apneic episodes lasting from 20 to 90 seconds, sometimes associated with cyanosis. It is an increasingly common condition, affecting around 10% of men and 5% of women and 1% of children. The prevalence is much higher in obese, elderly, or hypertensive individuals, and is also prominent in some patients with intellectual disabilities. The repeated stress of sudden arousal has significant cardiovascular and neuropsychiatric comorbidity and should be actively excluded when an at-risk patient present with hypersomnia, impairment of concentration and memory, or other psychiatric symptoms. Collateral history from a bed partner who is often aware of the sleeping difficulties is extremely useful. The diagnosis is confirmed by polysomnography with concurrent monitoring of electroencephalogram and respiration. Treatment comprises lifestyle advice, weight loss, avoidance of alcohol, sleep on one side not back, and provision of nasal continuous positive airway pressure. Okay. Lifestyle advice, provision of nasal, okay, PAP, okay, CPAP. Red flag. Obstructive sleep apnea increases the risk for road traffic accidents around sevenfold, and also increases the risk for systemic hypertension. It is a useful diagnosis to make as the majority of patients respond well to treatment with continuous positive airway pressure, CPAP. However, most cases go undiagnosed. Hints and tips. Medication and substances increase the risk for obstructive sleep apnea, particularly opiates, benzodiazepines, and alcohol. Always take a substance history in someone presenting with symptoms of sleep apnea. Sleep-related movement disorder. Restless leg syndrome is the commonest sleep-related movement disorder. Patients report uncomfortable sensation in their legs when at rest, typically crawling, burning, tingling, or itching, which are relieved by movement. Because inactivity is required for sleep, restless leg syndrome can delay sleep onset and precipitate awakenings. The disorder arises most frequently in young adults and generally worsens slowly over time, affecting around 1 in 50 people. In turns, it runs in families. Is twice as common in women and often occurs transiently during pregnancy. Okay, we're talking about restless leg syndrome. Okay. Medication can cause it, particularly lithium, antidepressants, antihistamines, and dopamine antagonists like metoclopramide and antipsychotics. Key differentials are peripheral neuropathy, not worse at night, vascular disease worsened by movement, not relieved, and akathisia, movement driven by an inner restless, not a specific need to move legs. So these are the differentials here. Okay. Okay. So, ferritin levels should be checked, as restless legs are a rare presentation of iron deficiency, which impacts on dopamine metabolism. Non-pharmacological management includes sleep hygiene, exercise, and avoidance of agents which may worsen symptoms like alcohol, caffeine, and medication. Pharmacological management is reserved for severe cases for short periods, like 6 months, and includes dopamine agonists like pramipixole and ropinirole, or anti-epileptics which binds voltage-gated calcium channels like gabapentin and pregabalin. This is alpha 2 delta or something. Non-REM sleep arousal disorders. Non-REM sleep arousal disorders are recurrent, incomplete awakenings from sleep during sleep stages out with REM. Generally slow wave sleep and generally during the first third of the night. The duration of the incomplete awakening is generally 1 to 10 minutes. but can be up to an hour. Okay. The two main subtypes are night terrors and sleepwalking. Walking. They are thought to share a common pathophysiology. Management is to exclude other diagnoses, offer reassurance, and advise good sleep hygiene. It is not necessary to attempt to terminate episodes, but it may be useful to remove potentially harmful objects and routes from around someone who sleepwalks frequently. Okay, sleep terrors or night terrors. Let's talk about that. Sleep terrors are episodes that feature an individual, usually a child, abruptly awaking from sleep, usually with a scream appropriate to be in a state of extreme fear. These episodes are associated with autonomic arousal, for example, tachycardia, dilated pupils, sweating, and rapid breathing, a relative unresponsiveness to the efforts of others to comfort the person who appears confused and disorientated. Upon full awakening, there is amnesia for the episode and no recall of any dream or nightmare. Sleep terrors are seen in up to 6% of children, aged 4 to 12 years, and usually resolved by adolescence. Sleep terrors should be distinguished from nightmares, panic attacks, and epileptic seizures. Panic attacks tend not to be associated with confusion, and amnesia is uncommon in them. Okay. What about sleepwalking or somnambulism? Sleepwalking is characterized by an unusual state of consciousness in which complex motor behavior occurs during sleep. While sleepwalking, the individual has a blank, staring face, is relatively unresponsive to communication from others, and is difficult to waken. When sleepwalkers do wake up, either during an episode or the following morning, they have no recollection of the event or having occurred. Sleepwalking is not associated with impairment of cognition or behavior, although there may be an initial brief period of disorientation subsequent to waking up from a sleepwalking episode. The peak prevalence of sleepwalking occurs at the age of 12 years, with an onset between the age of 4 and 8 years. About 2% to 3% of children and about 0.5% of adults have regular episodes. Okay. Sleepwalking run in families, with 80% of sleepwalkers having a positive family history for sleepwalking or sleep terrors. Nightmares. Between 10% to 50% of children aged 3 to 5 experience repeated nightmares, and they also occur occasionally in up to 50% of adults. Nightmares are characterized by an individual waking from sleep due to an intensely frightening dream involving threats to survival, security, or self-esteem. Nightmares are distinguished from sleep terrors by the observation that not only is the individual alert and oriented immediately after awakening, but is able to recall the bad dream in vivid detail. Furthermore, nightmares tend to occur during the second half of night because they arise almost exclusively during REM sleep. Okay, which tends to be longer and have more intense surreal dreaming during the later part of the night. Nightmares can be precipitated by withdrawal from REM suppressing agents such as antidepressants or alcohol, or by commencing beta blockers or dopamine agonists. Okay. Management is to reassure, avoid medications that may precipitate nightmares, and advise avoidance of stress. Okay. Hints and tips. Upon awakening from the rapid eye movement parasomnia, the patient is alert and recalls a dream. Patients who are awoken from a non-REM parasomnia are disoriented and confused with no recollection of a dream or their behavior. REM sleep behavior disorder. Unlike other parasomnia, REM sleep behavior disorder is more common in older adults, typically presenting in men in their 50s. There is a failure of muscle atonia during REM, allowing dreams to be acted out. The dream content is often of a negative and violent nature, so sufferers may jerk, punch, shout, get out of bed, or attack their partner. This occurs regardless of whether the sufferer has a history of violence and aggression. When awakened, patients often report very vivid, intense, threatening dreams. Often, patients present because of injuries to themselves or their partner. The behaviors are more frequent in the last third of the sleep period and can occur cyclically, as REM sleep occurs approximately every 90 minutes. There is a strong association between REM sleep behavior disorder and neurodegenerative conditions involving abnormal deposition of synuclein protein in Parkinson's disease or Lewy body dementia or multisystem atrophy. Over half of patients will go on to be diagnosed with Parkinson's disease, potentially up to 10 years later. The sleep disorder can improve as the neurodegeneration progresses. Management include environmental modification to reduce injury, couching around the bed, removal of potentially dangerous objects from the bedroom. Clonazepam is highly effective in reducing the behavior up to 90% of cases. Interestingly, tolerance does not seem to arise, so it can be continued long term. Red flag: rapid eye movement sleep behavior disorders often arise in the early stages of neurodegenerative conditions such as Parkinson's disease and Lewy body dementia. Careful assessment and monitoring of neurological status are needed about REM sleep behaviors. Chapter summary. Sleep can be disrupted due to a primary sleep disorder or a psychiatric condition, a medical condition or substance use, prescribed medication or recreational. Dysomnias are characterized by abnormalities in the amount, quality, or timing of sleep. Parasomnias are characterized by abnormal episodes that occur during sleep or sleep-wake transitions. Good sleep hygiene, ensuring sufficient duration of sleep, and avoiding recreational substances are recommended for all patients with sleep problems. Hypnotics can be helpful for short-term use in insomnia, but lose effectiveness if continued long-term. So that's it. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.